And now to proceed with Symposium 24, the EFIM and CCP Joint Symposium for Young Internists, exploring opportunities, challenges, and the future of internal medicine training. It's my pleasure to invite our chairpersons, Dr. Chanaka Abeyratne and Dr. Prabhashini Kumarihamy. And I warmly invite our chairpersons to introduce the speakers and panelists for the session.
Good evening. We have come to the end of the 58th anniversary annual academic sessions. I think this is the last symposium of the Congress and the day. We have joint symposium with European Federation of Internal Medicine and Ceylon College of Physicians. We have 4 lectures lined up. I would like to invite our first speaker, Professor George Dalekos. He is the President of the European Federation of Internal Medicine and the Head of the Department of Medicine at Larissa University Hospital, Greece. Over to you, sir.
Thank you very much, Mr. President. And once more time, I would like to thank the organizers, the CCP Council, particularly the President, Professor Prasad Katulanda, and all his group, Dumitha, Lilanthi, Praviren, I don't remember, sorry, maybe I forgot somebody that have communicated with me several months ago to be here today. And I would like to thank because you gave us the opportunity to present the activities of the European Federation of Internal Medicine here today, and particularly for the young internists. The Executive Committee of EFIM, the EFIM is governed by the Executive Committee, which is consisted by the President, the President-elect, the immediate past President, as you can see in the slide, the Treasurer and the Secretary General, and of course the column of EFIM is our Executive Manager, Mrs. Aneta Trajkowska. We are very proud because EFIM currently comprises about 48 member societies, ordinary and associate members, and you can see in the bottom line there is a CCP, which is also associate members during this year. And we represent more than 60,000 internists worldwide. The Young Internist section is governed by the President, Miguel Romano, and also the Secretary from the Italian Society, and there are also 3 other members. This is a subcommittee of EFIM, with doctors in training in internal medicine from early years of the senior posts and up to 5 years after the specialty of internal medicine, irrespective of their age. We have also an early career subcommittee. You can see here the current subcommittee with 5 members from several countries. We are very proud for our journals, particularly for the European Journal of Internal Medicine with the editor-in-chief, Professor Giancarlo Agnelli. But we have also the European Journal of Case Reports in Internal Medicine, which is indexed in PubMed by the editor-in-chief, John Kellett, and is very important, I think, for the young internists. You can see here that EGIM has a very good impact factor, 6.1, I have to say that the European Journal of Internal Medicine during the last year was one of the 15% of all the journals that increased, even a small increase, but increased their impact factor, because several journals, including New England and Lancet, decreased in a great proportion. Here is the case report journals. We have applied already for an impact factor, and we hope that during the next year we shall have, but this is not very important, I think, because the case reports journals are not very high, but it is very important to apply to the web of science. We have organized several webinars that are free in our web channels. As you can see here, some of them in several hot topics of internal medicine. We have the European schools of internal medicine twice per year, one in winter and one during summer. Here you see some hints from the last winter school in February in a very small town in the very north of Sweden. And here is during the summer in the northeast edge of Greece. We have approximately 50 to 60 participants. And this is very, very important, of course, because it's 1 week education during these European schools of EFIM. We have also a platform of education which is free for our members. This is the EFIM Academy. Here you see the editor-in-chief and the associate editor. And there you can follow several modules, webinars, courses, 1-minute learning, podcast, congress presentation, etc. And all these are free of access to all of our members. We have also very close collaboration with EFDIM. EFDIM is the foundation for the development of internal medicine in Europe. And as you can see characteristically from the slide, EFDIM organizes a clinical research seminar annually. This year is in October in Paris, France. And this is organized by EFIM and EFDIM equally. EFDIM offers also 4 bursaries for the European school, I told you previously, support the exchange program that I will talk later on, and support with prizes the European Congress of EFIM. We have also in EFIM the working groups, very, very important groups. You can see here the Choosing Wisely group, the Critical Appraisal for Guidelines working group, the Multimorbidity working group, the Telemedicine working group, the Ultrasound working group, which is very famous, the Acute Medicine and Hospital Medicine working group, the Diabetes and Obesity, the Heart Failure and Infectious Diseases. And during this year, we launched 2 brand new working groups with the French Society of Internal Medicine, which are the systemic autoimmune diseases and the rare diseases. You can become, if you are an EFIM member, you can become a fellowship of EFIM, and you can see the requirements in our web page. Up to the present, we have 168 fellows, and you can see here the numbers. during the last European Congress of Internal Medicine. And here is some photos from the EFIM fellowship ceremony during the last ESIM in Florence, Italy. We have also the exchange program, which from my personal point of view is the most important, because we have 36 hospitals around Europe, very well qualified, and the residents can go there for 1 month, and we are giving 10 scholarships of 1,000 euro per year per participant, along with FDIM. As I told you, we have close collaboration, and now the new executive committee intends to increase the time to 2 months and to increase the scholarship. We'll see. After October, we shall have the final decision on this. And here is what the residents, what our participants had to say about their experience in a film exchange program. We have also some other collaborations, for instance, here with Walter Kluwer for the up-to-date, and we are working for potential collaborations with AMBOS, a very big database in the internet. I'd like to thank you again and not forget our next European Congress of Internal Medicine in Vienna during the 25 and 28 of March next year. It's not 2025, it's 2026. And here you can see this logo and to save the date. Thank you very much indeed for this opportunity.
Thank you, Professor Dalekos, for exploring the opportunities for young internists at the European Federation of Internal Medicine. So our next speaker is Miguel Romano, who is the chair of the Young Internist section of the European Federation of Internal Medicine, where he leads international initiatives to promote education, networking, and professional development for young physicians across the Europe. So his topics today is navigating a career in internal medicine without burnout. So over to you, Professor.
Hello, everyone. My name is Miguel Romano. I'm the chair of the EFIM Young Internists, and it's deeply an honor to be present in this conference. I'm an internist. I'm also doing the training to the intensive care specialization. Outside the hospital, I've been working with some medical associations, and I'm the CEO of 2 medical companies. And for the past 5 to 7 years, burnout has been one of my battles. And so it's an amazing opportunity to be here and presenting to you, navigating a career in internal medicine without burnout. So I do not have any conflict of interest regarding this presentation, and this is a small index of what we will be discussing: an introduction in burnout from 1 to 3 topic, and then why burnout matters, the strategies that we can use to fight burnout, and some take-home messages. So, as the title or the theme of this Congress will be the physician of the future, I thought that would be nice to start with a powerful message. And that there is that the physician of the future cannot be built on the exhaustion of the physician of today. And that's a huge message. So we have to start working now and to tackle burnout in order to have a better physician in the future. Internal medicine is, of course, the backbone of modern healthcare. It's what we present ourselves, but this comes with a cost, of course. We are not only the connection between specialties, we manage complexity and we take care not only about the patients, but also about their social topics and families. And it's scary to notice that in Europe, half of the internal medicine residents show signs of burnout. And even when we consider residents and specialists, so internists, over 40% of internists report emotional exhaustion. So what is burnout? Let's start answering this question. Herbert Freudenberger in 1974 starts working on this topic, and he said that there is a proneness to burnout on those who work too much, too long, or too intensely. And it's funny to take into account that the name burnout came from drug culture slang. So it was referred to people that had used drugs and now are lost their all their energy. So that's where the topic comes. But Herbert described burnout as a mental and physical exhaustion caused by work. And he noticed it when he watched volunteers that started working motivated, but then gradually lost their energy and passion. A few years later, with Maslach and Susan Jackson, burnout became a syndrome, a multifactorial syndrome, and it was based on three bigger dimensions. So emotional exhaustion, depersonalization or cynicism, and reduced achievement at work. And this is actually important because since 81 until the present day, the definition is pretty much the same. So we can say that burnout is a dysfunctional reaction to prolonged work stress, but the WHO says and defines burnout as a syndrome resulting from chronic workplace stress that has, again, three dimensions: emotional exhaustion, depersonalization, or the reduced sense of professional accomplishment. A small historical and also funny note. So as we've been discussing, burnout it means burning until exhaustion. And so we can conclude that the more the work, the greater the risk and the greater the burnout. Funny to say that work in Portuguese is called trabalho, and this comes from a Latin word, tripalium, that is an instrument of torture made of three crossed wooden stakes, which slaves were tied to be flogged. So in Portuguese, at least, the word work starts with the torture, an instrument of torture, and now it's the daily lives of everyone. It's work. Another powerful message that I really want to leave here is that burnout, it's not a binary thing. It's not an on and off switch. It's not you have it or you don't have it. Burnout comes as a spectrum, and it can be also justified or understood with the three dimensions that we just talked. Burnout can present itself as different ways of signs or warning signs, but it's a continuum. You would start as an healthy engagement, you'll be motivated, you'll be interested in your work, but then you can go and fall through some categories with early warning signs as fatigue or irritability, chronic stress, and the full burnout, where exhaustion and depersonalization would happen. And again, another tricky part of the burnout and of the spectrum is that different people manifest it differently. Of course, we are different human beings, we work differently, we have different motivations. And so if one physician may look like fatigue and irritability and with some emotional exhaustion, another one can just seems detached or with the loss of empathy. And again, others will just manifest themselves with the feeling of underachievement in work. So we have to bear in mind that the burnout doesn't wear the same mask on everyone. It can affect individuals differently, and those individuals will present the burnout, the disease in a different way, and all of us must be prone to identify those things. And of course, as I just said, early recognition is the key. We have to know that burnout is a spectrum, and we have to be aware to recognize it early. So we don't need to wait until the fire is out of control or the fire is actually out. the smoke should be an enough reason to act. And of course, if we wait too long and we are fully burned out, the recovery will take longer and it will be, of course, harder. And for this to happen, we have to have a proactivity approach. We have to encourage other physicians and the systems to monitor themselves and their peers. We have to normalize talk about stress, about mental health, about burnout before it reaches a crisis. And we should try to build some checkpoints, even weekly or daily, to reflect on the energy, on the stress levels, on the balance that we have at work, and try to identify early the warning signs that we've been discussing. And after this small introduction on what is and how to identify burnout, it comes the question why burnout matters, why we are talking about this. And the answer is pretty much simple. Burnout matters because it's impacting the healthcare outcomes in a variety of ways. So it can impact physicians, it can impact patients, and it also can impact systems. So regarding the physicians, why does burnout matter? It matters because of us, the physicians. Burnout is linked to higher rates of depression, substance abuse, and even suicide among doctors. And some investigation done worldwide, doctors have a 2 to 5 times higher rates of suicide than the general population. Burnout can also lead to early retirement, worsening the global physicians shortage. And another important thing is that burnout, unfortunately, does not stay in the hospital. It does not end when the shift ends. So also our families at home will suffer from this absence, even physical or emotional, and relationships and the stress at home can be aggravated because of the feeling of burnout. Continuing with some actual and palpable data, and meta-analysis that went through on 41 European countries using the definition about the dimensional Maslach burnout inventory that we talked earlier, it found out that 7.7% of physicians actually identified themselves as having burnout in all 3 dimensions, almost 20% with 2-dimensional definition, and almost half, 43%, with 1-dimensional measure. As we said before, burnout is a spectrum, so each and every one of these percentages are meaning that doctors are having burnout, one on the end of the spectrum and the others on the beginning of the spectrum, so to speak. Another meta-analysis, and this one was for residents across all specialties, reports that internal medicine residents face burnout at 57.1%, which is a huge percentage, only beaten by intensive care and emergency physicians and residents. So we should be aware. Another thing that I want to bring here is a study from last year, from 2024 in the UK, where 63% of trainee doctors are at high or moderate risk of burnout, being the ones from emergency medicine, the ones at higher risk. This is the news from The Guardian, which I found it really interesting because it was a huge journal and was promoting this kind of discussion. And also the actual study, for anyone who wants to find it, the National Training Survey from 2024, it's easy accessible. So if anyone wants to know a little bit more about this study, just try to find the study. And within the young internists, we also had our own study regarding burnout. And we went for almost 500 answers. And it was also scary to notice some notes. I brought you here some of the questions that we made, and this one was just about the work and the time spent in the hospital. And more than 67% have 8 hours, more than 8 hours per day at the hospital. And almost 90% said that they would spend more than 8 hours in the hospital regarding their work and more than their initial hours, regarding the 24-hour shifts, more than 5 per month for 30% of the people that answer this survey. Excessive workload for 62%, and more than half of and 65% said that they were doing paperwork and medical records more than 50% at the time that they should be with the patients. Continuing with the same study, we asked to the participants how they feel about the work. So 64% felt always or usually stressed, 55% exhausted, 46% anxious, and almost 20% disconnected from their work. And finally, when we actually asked if they were suffering from burnout, we divided it into a little, a moderate, a lot, or a great deal, but they are all stages of burnout. So we can say that 77.3% of the almost 500 young internists from Europe are feeling burnout. And more scary is that 92.3% say that either they do not have a support system or they do not know if they have a support system for burnout within the hospital. This is alarming. These are huge numbers, and this is a huge survey that we made. So we must be aware of these numbers and try to tackle them as soon as possible. But it's continuous. Burnout doesn't affect only physicians and their families, it also affects patients, because burnout doubles the risk of medical errors and decreases empathy at the bedside. And this will, of course, lower patient satisfaction, reduce trust in the system. And also here we have some studies, and studies linking clinical burnout with patient safety show that errors linked to burnout occur in 1 to 10% of hospital admissions, and this is huge. And also, they managed to find that it can contribute to roughly 3.5 billion in costs for the healthcare regarding the burnout and the medical or errors that come from it. And finally, on the system, of course, it also has impact on the system because the physicians are with burnout, they either leave, so the absenteeism and costs to replacement will get huge. They will make more mistakes, also, as we saw, more costs to the healthcare. So we do believe that the way forward is to consider burnout not just as a personal issue, but also as a public health problem. So how can we fight it? I began to wonder which was the best way to present these slides. So I will start by saying what has been done in Europe and how it can be helpful. And for example, the Schwartz rounds, and I will encourage you to try to find them. And there is a lot of information out there on how to do it. And this is a multidisciplinary meeting between physicians, nurses, and every kind of technicians or health professionals at your hospital that would meet 1 time a week, 1 time a month. And they would discuss only the stress, the emotional pressure that they feel at the hospital. And they found out that this stress would be reduced in almost 20%, and that people would feel more compassionate about each other. Other things that have been done in the NHS in the UK is that you can have access to mental health clinicians to improve. They are having frameworks for well-being that are reducing absenteeism and increasing job satisfaction. And of course, identify and correct the organizational mistakes or errors that are being there, as the rotations, protect breaks, and of course, less bureaucracy, mainly for physicians. We know that that's a huge thing that are keeping us from doing our work. Again, the policy at Europe has been changed, so it's now trying to treat us as an occupational risk more than an individual problem. The workload, we are trying to change it. Less night shifts in emergency or ICU if possible. And of course, the service. We have done it. There are plenty worldwide. We have to know and to measure how it is to correct it. Finally, in an individual perspective, what can we do? Of course, mindfulness and cognitive behavioral therapy tools are huge help for professionals. It's proven that it reduces stress. Physical activity and hobbies are also helpful. Mentorships and peer network, and reflect on the medicine, why we are here, what we are doing, why are we doing it, and try to counter the depersonalization of the burnout. So keep the focus on what we love doing and the people we are saving, and try to stay identified with the work that we are doing. And of course, at the enterprise or the Euro perspective, organizational intervention will always be bigger and with better outcomes than individual one. Treat burnout as a psychosocial risk, and measure, intervene, and measure again, and repeat the cycle in order to improve the outcomes. So what you can do tomorrow, try to start Schwartz-style rounds, 1 hour a month, multidisciplinary, no blame rule. Protect the breaks, so you have to have breaks during your work schedule. They have to be there, just schedule them and protect them. Try to identify the problems in your admin, try to correct it and text it. Try to limit the nights and have healthy rotations within your work. As I said, mentorship and peer support. Do pairs between young and older residents. Try to have meetings 1 a month. Try to open spaces for people to talk and see how it goes. Again, fast-track mental health access. So every hospital should have the access to psychology or psychiatrists for physicians. Try to improve your micro skills. Try to measure and act on everything that you identify as a risk for the burnout. Healthy basics: work well, rest well, sleep well, and of course, try to identify the groups in higher risk as residents, and try to do reforms targeted for those public. And so finally, I hope you enjoyed this small presentation about burnout. And burnout is real and it needs recognition. Vulnerability is not a weakness. It's part of being a human, and everyone should be comfortable in admitting that. Systems must care for doctors because doctors care for patients, so that should be a priority. And when I say doctors, I'm talking about healthcare professionals. Prevention is better than to cure. The burnout, when it's full on, it's difficult to cure, it's difficult to take over, so you should act early. The professional longevity will increase if we tackle burnout. Support your colleagues. As I said, notice the smoke before the fire. And recovery from burnout is, of course, possible. It will take time, it will take help, and it will take honesty from yourself to recover. So even superheroes will need a break. Here's an example when Tom Holland announced that he will take a break for mental health. And take care of yourself, because the entire system depends on it, you included. So thank you so much. I will leave here my personal and work email if you want to reach out. And any questions or any doubts, I'll be more than glad to talk to you. Thank you so much for the invitation. Thank you for the opportunity, and we'll see you soon.
Thank you, Dr. Miguel Romano. We will call for you again at the end of the symposium for the panel discussion. Our next speaker is Dr. Dumitha Govindapala. She's a senior lecturer and consultant physician from the Department of Medicine, University of Sri Jayewardenapura. She will be talking on At the Crossroads, Challenges and Opportunities for the Next Generation Internists in Sri Lanka. Over to you, madam.
Thank you, Chanaka, for those kind words of introduction. So good afternoon, everyone. I think it's almost evening. First of all, I would like to thank the President and the Scientific Committee of the annual academic sessions of the Ceylon College of Physicians for giving me this opportunity. So, every young internist eventually reaches this crossroad, usually after completion of your overseas training. The question then is, Do I continue my career here in Sri Lanka or pursue opportunities abroad in places like UK or Australia? It is never an easy decision, but it is exactly at this moment, this your choice, that shapes not just your own futures, but also the future of internal medicine in this country, which is why I chose this topic at the Crossroads, Challenges and Opportunities for the Next Generation of Internists in Sri Lanka. So, over the next 15 minutes, I would like to give you an insight into what it could look like if you decide to stay in Sri Lanka and invest your time, skills, and expertise here. So if we look at the Sri Lanka's healthcare landscape, we actually have a very strong public healthcare system. We are lucky to have highly literate population, and our medical training standards are on par with the developed world. At the same time, the private sector is expanding and creating new opportunities for practice and innovation. But of course, our healthcare system faces many challenges. Limited social services, uneven distribution of resources, and difficulties in delivering healthcare to remote and rural areas are some of the key issues that we face. At the same time, disease patterns are shifting from mainly communicable diseases to a rising burden of non-communicable diseases. So why internists matter in this healthcare system? We internists are the backbone of our healthcare system. Our role goes far beyond day-to-day patient care. We are the ones to diagnose complex diseases, often when the answers are not so obvious. We coordinate care, and we ensure that our patients won't get lost between different specialties. It is our responsibility to teach and mentor our next generations and to pass not only knowledge, our values. Also as internists, we are to lead in research and policy, shaping how healthcare evolves in this country in years to come. But the role of young internists is never easy. You will face numerous problems, challenges every day. We can broadly categorize these challenges under 3 headings. First, systemic and institutional challenges. Our hospitals are often overburdened with patient numbers far exceeding capacity. On top of that, our resources are stretched. We have limitations in diagnostics, shortage of ICU beds, and sometimes even restricted access to essential medications. There are also the reality of a hierarchical culture, which can make it harder for young internists to contribute or have their voice heard. Not only that, in clinical practice, we are seeing a rapid increase in non-communicable diseases and mental health issues, demanding much more of our attention. Like in many other countries, we are facing a rapidly aging population, which brings a whole new set of healthcare needs. Also, antimicrobial resistance is another emerging threat in the field of internal medicine. When we talk about career, professional and personal growth, young internists face numerous challenges. opportunities for specialized training within internal medicine are still limited. This can affect both career growth and the development of expertise among young internists. There is also limited research infrastructure, which make it difficult for those who want to contribute to evidence-based medicine and those who want to pursue academic careers. Work-life balance is also another big issue. Long hours of work, high stress levels, and burnout are common among internists, as you witnessed in the previous presentation. Financial pressures add to this, especially when the salaries are not matching the workload and our expectations. For those with families, there are additional challenges. Finding schools for children or being separated from families when you are posted to remote and rural areas. Albert Einstein once said, "In the middle of every difficulty lies opportunity." So, what are the hidden opportunities for you all, for the young internists in this country? First, opportunity for subspecialization and innovation. We are witnessing emergence of fields that didn't exist a decade ago, such as geriatric medicine and palliative care. Infectious diseases is another critical area that remain largely untapped and presents a compelling opportunity for those looking to pioneer and shape a field from the ground up. You as the young internists, have the opportunity to establish many subspecialty services which are not existing at the moment. At the same time, technology is opening new frontiers in healthcare, from electronic medical records and telemedicine to AI-driven diagnostics, have the potential to enhance efficiency, accuracy, and standards of patient care in this country. These tools are not yet widely adopted in our healthcare system, so you could be among the first to lead this transformation. When it comes to research and academic leadership, the opportunities for young internists are substantial and wide-ranging. There is a clear need for high-quality, locally relevant research that addresses the unique healthcare challenges of our population. Whether it is a clinical research, healthcare improvement, or curriculum development, there is ample room to lead, innovate, and make a lasting impact in this country. Also, there is a huge potential for interdisciplinary and international collaboration, which allows to bring global expertise and innovations to Sri Lanka. Another important avenue for young internists is active involvement in professional bodies like Ceylon College of Physicians, the Postgraduate Institute of Medicine, and the other professional organizations. These roles offer the opportunity to contribute beyond clinical work. Through this form of leadership, internists can play a vital role in steering the future of healthcare in Sri Lanka, not only at the bedside, but across the entire system. We at the CCP conduct so many activities for professional development and improvement of the standards of healthcare in this country. So I invite all of you to be part of us. Also in Sri Lanka, internists have a vital role to play in a national health leadership, especially by engaging with the institutions like the Ministry of Health. There is a real opportunity for you all to help shape the health policy ensuring the policy decisions are guided by clinical insight, and that the resources are used fairly and effectively across the country. Internists can also lead the way in developing locally relevant evidence-based guidelines so that care across the country is safe, consistent, and meets global standards while still addressing our unique needs. I wish to pause for a moment and talk openly about something we usually whisper about: migration. Many of our young internists are leaving Sri Lanka. You are watching your friends and batchmates leave for fellowships in Australia, the UK, or New Zealand. They have access to structured training, advanced technology, well-established systems, better salaries, and better work-life balance, while you all are managing 80 patients during your ward rounds, chasing down lab reports, teaching undergraduates, studying for exams, and doing it all while trying not to burn out. It's exhausting, and it's real. But here's the other truth. Every health system needs people who stay, who build, who lead. Staying isn't the default or the second best option. It's a deliberate choice, a decision to invest your skills where they are needed most. If you stay, you are not just surviving a broken system. You have the power to shape a better one. You can pioneer subspecialties, raise the clinical standards, transform teaching, and lead policy reform. You can bring new ideas, technologies, and practices into place that needs them and change the future of healthcare in this country. And now, let us look at what this choice can actually lead to, not in theory, but in practice. I want to share the stories of 3 young internists who made the decision to stay. They saw gaps in the system, not as obstacles, but as opportunities. They stepped forward, took up the challenge, and established services that didn't exist before. Each of them showed us what is possible when you choose to lead from within. Dr. Dumitha Govindapala, he initiated dialysis services at Base Hospital, Padavia, raising funds through donations. He provided services for thousands of patients suffering from chronic kidney disease. Dr. Dilha Samaravira, who contributed immensely to establishment of geriatric medicine in Sri Lanka. Dr. Udayangani Ramadasa, who pioneered palliative care services in Sri Lanka. Their work is a testament to what is possible when expertise is invested where it is needed most. So, at this crossroad, make your decision carefully. One road may lead to comfort and predictability. Other road may be harder, but has many opportunities in the chaos. Choose the path of impact or escape, because this country needs not just doctors, but leaders, builders, and believers. Be the person who makes a change that will be more rewarding than many other comforts in life. Thank you.
Thank you, Dr. Dumitha, for that insightful talk that allow our young internists to rethink about their life and the professional career. So our next speaker is Dr. Keshani Samarasekara. She is a board certified specialist in general medicine with dual registration in UK and Sri Lanka. She currently serves as a consultant in acute medicine at Royal Liverpool University Hospital. So she'll be talking about integrating overseas training and artificial intelligence into the critical practice of the young Sri Lankan internist. So over to you, Dr. Keshani.
Thank you, Dr. Prabhashini, for that kind introduction. I would like to thank the Ceylon College of Physicians for giving me this opportunity to speak to you today. It's a real privilege to be here today, speaking not just as a physician who has trained and worked both in Sri Lanka and the United Kingdom, but also as someone who is passionate about the future of clinical medicine in Sri Lanka. I'm currently working as a consultant physician in acute medicine at the Royal Liverpool University Hospital. I have no conflicts of interest to declare. This is the outline of my talk today. I will be discussing about how two transformative forces, overseas training and artificial intelligence, can empower the next generation of internists in Sri Lanka. And if we intertwine these two transformative forces into our practice thoughtfully and effectively, we can make a meaningful impact in the Sri Lankan landscape, like how Dr. Govindapala mentioned it during her speech before. So let's start by a quick look at where the internist in Sri Lanka is currently at. And I wouldn't go into much detail here because this has already been discussed in the previous talk. But to summarize it briefly, there's rising clinical demands, partly due to the migration of colleagues abroad. There is a higher clinical load that needs to be carried by the remaining colleagues. And also, there's a significant limitation of resources due to economic constraints and various other factors. And on the other hand, there is an increase in the expectations of the patients, especially because now they are informed and sometimes misinformed due to the availability of a lot of information on social media and also through generative predictive text tools like ChatGPT. And while we try to keep pace with the expansion of medical knowledge, it is expanding ever so rapidly, and it's not realistically possible to keep up with all the latest advances. So, on the other hand, we are also living at a time of opportunity because the global connectivity, digital health, and cross-border collaboration can act as real force multipliers if you use it wisely. So adaptability and a willingness to innovate is key if you want to make the best out of any situation. When we think about training in the UK or any other international center, it's not just about getting more clinical exposure. It's also about adjusting the mindset of how you work as a clinician. So when you work in these developed systems, you get exposure to structured systems and delivering evidence-based care at the point of delivery. And these structured decision-making protocols will help you to balance your own clinical autonomy with the wisdom of the team input. And multidisciplinary collaboration with other allied health professionals, nurses, and pharmacists is another aspect that you learn when you work overseas. And there's an exposure to a strong culture of quality improvement, which helps you to reflect and refine your practice. And there's a real emphasis on soft skills in addition to your technical skills. So it's important to learn how to lead, how to maintain your empathy even when you're under pressure, and learning communication skills as well. And overseas training gives you a different lens for looking at local systems, and it's often, you should use that to look at these systems with curiosity and see possibilities where you can improve the Sri Lankan system with the knowledge that you gain from your overseas exposure, and bring that sense of possibility back to Sri Lanka when you come back. So how can you translate this knowledge to the Sri Lankan systems and uplift your clinical practice? One way is through clinical governance systems like morbidity and mortality reviews, small-scale audits, which can be done even in regional hospitals, and also establishing feedback loops to improve and develop your practice. And it's also important to build a mentorship culture locally. It could be in the form of peer teaching or virtual clinical discussions, or even virtual case rounds with your colleagues abroad. And then you can adapt international protocols to suit your local realities based on simplified care pathways, which are suitable for the local drug availability and referral patterns. And finally, it's important to continue your reflective practice. It's always useful to take a moment to think back, reflect, and see what went well, what didn't, and then learn how to do it better the next time. So let's turn to the second major theme of my talk today, that is artificial intelligence. So it might sound like a very abstract and distant concept and might even sometimes sound intimidating, but at its core, it's really quite simple. It's the ability of machines to process large amounts of information, pick up patterns in that information, and give us predictions or insights based on that. And in reality, on a daily basis, we engage with artificial intelligence in multiple ways. For example, when you search PubMed or Clinical Key for information, there is artificial intelligence in use. And also, if you use Google Translate to communicate with a patient who speaks a foreign language, again, you are engaging with artificial intelligence. So just to give a brief idea of the capabilities of artificial intelligence, what we use mostly now in our daily lives is what's called artificial narrow intelligence. These are essentially like one-trick ponies. They're trained to do one thing and programmed to do one specific task. So unlike that happens in science fiction movies, these artificial intelligence will not suddenly start doing something that it was not programmed to do. And then there's a theoretical concept called artificial general intelligence. This is what the AI engineers are currently striving to achieve. This is a human level intelligence that's able to understand, learn, and apply knowledge across many different domains. So it will be similar to a human that could adapt to new situations and learn new skills without needing to be programmed for each and every step. And then finally, there's super intelligent AI, which is a hypothetical version, which is only in the realm of science fiction. And that is a form of intelligence that surpasses human intelligence. So if you look at how these machines learn, at the core is a concept called machine learning. And that's how systems learn from data without us having to program every single rule. So within machine learning, there's various different approaches. Supervised learning is where the data is labeled, and it's how the AI learns to match inputs to outputs. And then unsupervised learning is where the data is not labeled, and the machine itself learns how to recognize patterns and give us predictions. Reinforcement learning is a form of learning through trial and error, where the machine gets positive or negative feedback based on how it performs. And then building on these types of learning, there's a concept called deep learning that uses complex neural networks to learn complex tasks and analyze complex data. So if you look at this, it's kind of similar to how humans learn as well. And the difference is the machines are sometimes better than us at processing large amounts of information. So how can we utilize AI in medicine? It could be used in three main ways. For clinical decision support, it could be used in diagnostics. Like, for example, we can use AI systems to pick subtle arrhythmias in ECGs that clinicians might not pick up, and then spotting early pneumonias on chest X-rays, and flagging suspicious skin lesions in dermatology. And it can also be utilized to guide treatment decisions, like suggesting medication dose adjustments based on patients' comorbidities and lab results. And AI is also quite useful for workflow improvement, especially if you work in a setup where you have to do a lot of documentation. AI can really take off most of the routine stuff off of our plates. It can help you to automate discharge summaries, summarize patient notes, and using voice-to-text tools in wards and clinics to reduce the burden of paperwork and spend more time with your patients. Predictive tools are early warning systems that would help us pick up patients who might deteriorate quickly before it becomes obvious, and then hopefully improve the outcome by intervening early. Currently, there are systems that are helpful in flagging up patients with early signs of sepsis, and systems that predict those who are at high risk of readmission. So can we really use AI here in Sri Lanka? The answer is absolutely yes, and it is already in use. And some of you in the audience may be already using some of these systems. So something very simple that everyone can use is mobile-based clinical tools that be simple calculators, and some of these will have decision-making prompts based on the scores that are used in the calculators. For example, MELD scores for liver disease, CHA2DS2-VASc scoring for atrial fibrillation risk, stroke risk in atrial fibrillation. And these calculators will help you to make your decision-making more faster and streamlined, and will be quite useful in settings with higher clinical loads. And AI-enhanced radiology reporting is a real game changer. And this helps, these AI systems help to flag subtle radiological findings on radiological imaging, which a radiologist might miss due to being quite busy, or sometimes the changes might be so subtle that we might not pick it up with our human vision, but the computer vision that the machines use might be better at picking it up. And this will definitely improve the accuracy of reporting in radiology. And telemedicine with AI triage is another useful tool, especially in the Sri Lankan setting, if this can be established in rural hospitals, because this would prevent the patients needing to travel long distances to get to tertiary care hospitals, because the patients can be assessed remotely and be prioritized according to their clinical severity, and to decide whether they need urgent attention at a tertiary center or whether they can be managed locally. And this will improve access to specialist services to underserved areas. And ChatGPT and other similar generative predictive text analysis tools can be used to summarize recent guidelines and latest research papers to keep up to date. And this is quite useful if you are busy and you have limited time to continue your medical education. And sometimes when managing complex clinical cases, it is useful to use these tools to generate a list of differential diagnoses. And it's important to make sure that that you use this as a supporting tool rather than something that replaces your clinical judgment. And so the key here is that you don't need cutting-edge infrastructure or huge budgets to start using AI. All you need is a willingness to try, experiment, and adapt these tools to the local context. Just like anything else, AI is not without challenges and ethical concerns. One of the big issues is algorithmic bias. AI is trained on data. The output that the AI gives you is dependent on the data that it's trained on. So if it's trained on data from patients overseas, the recommendations that it gives you might not be relevant to your patients in the local setup. And there will be some context mismatch if local data is not used for training the algorithm. So it's important to collaborate with AI developers and tailor-made tools that is valid for the Sri Lankan setup. And data privacy and regulatory gaps are a major concern, and therefore strong policies and clear guidance needs to be developed on responsible AI use. And there is a risk of over-reliance on technology, which could weaken the clinical intuition of clinicians. So like I said before, it's important to use this as just a support tool and not as a replacement. And this is something we need to emphasize when we train the junior doctors, that they should not overly rely on these AI tools alone. And there's a potential for academic dishonesty and undermining the quality of training. With easy access to AI, students and trainees could resort to using these tools for their assignments or their other activities related to their training. So the way forward is to integrate AI responsibly into medical education and using it to enhance learning rather than replace the standard learning protocols, and to promote a culture of accountability within trainees and students. And so AI has huge potential, but we need to approach it thoughtfully and combine innovation with ethics, local adaptation, and strong governance. So this guide from the Alan Turing Institute gives a really clear framework for designing and using AI responsibly in the public sector. And it stresses on the importance of thinking ahead to prevent potential harms of AI. So I think it might be useful to develop a similar guide for the Sri Lankan setup to address challenges, especially with things related to algorithmic bias and data privacy concerns, and see how AI can be fitted into the Sri Lankan clinical workforce. And it's important to collaborate with clinicians and regulatory bodies and AI experts to try and develop a framework that is practical, relevant, and actually useful for clinicians on the ground. So the internist of tomorrow isn't just a clinician. They are a hybrid that combines local expertise with international insight and tech savvy. And it's important to be clinically grounded in the Sri Lankan realities, understand the local healthcare system, the challenges that we have to face, and the needs of the patients, and at the same time be digitally enabled and comfortable using digital tools and AI to support decision-making, streamline workflows, and improve patient care. It's also important to be globally informed with the exposure from overseas training and with other opportunities to collaborate overseas. It's important to use these, the knowledge and adapt it to the local context. And it's important to be a lifelong learner and mentor, staying up to date with medical advances and sharing that knowledge with your peers and guiding the next generation of clinicians. The internist of the future is a patient-centered, tech-informed, globally aware person, combining the best of local grounding with the power of innovation and collaboration. So there's a few action steps for young internists to be able to prepare for the future. It's important to pursue global exposure through training or via attending international conferences or online collaborations. And it's important to experiment with AI tools to learn what works and what doesn't, and think critically on how to use them responsibly in the local setup. And it's always useful to share what you learn, be a mentor to your peers and to juniors, and try to embed audit and quality improvement in your practice. Even small steps like tracking outcomes, reflecting on cases, and making small adjustments can make a big difference over time. And throughout all of this, remember to stay curious, stay skeptical, and stay engaged. Curiosity will drive innovation, skepticism will keep you safe, and engagement will make sure that you actually make an impact. So overseas training gives us new perspectives. It helps us to see our local practice through a global lens. And on the other hand, AI offers scalable solutions to help us work smarter, faster, and effectively. But at the heart of medicine is something AI probably cannot replace, because it's a human connection between the doctor and patient. And the trust, empathy, and understanding is what makes our work meaningful. So this is probably why AI will never replace doctors. So it's important to adapt wisely, be open to new technologies, new ways of working, and new ideas. Lead humbly, guide others, share your knowledge, and mentor the next generation, and care deeply about maintaining that human connection with our patients, especially when medicine becomes more digital and data-driven. So taken together, these three principles will give us a roadmap for practicing modern medicine responsibly, embracing innovation while staying grounded in ethics, humility, and humanity. So thank you all for listening. If you'd like to stay connected, feel free to scan this QR code and connect with me. Thank you very much.
Thank you, Keshini. You can sit here, and let me to call upon our previous three speakers, Professor George Dalekos, Dr. Dumitha Govindapala, and the virtual, I think, Dr. Miguel connect with us. And please, our three panelists, Dr. Rakitha Higgoda, Vihangi Fernando, and Solith, please come to this stage to start our discussion.
Now the forum is open for discussion. So if panelists has any questions, you can ask.
I'd like to raise a question to Dr. Keshini, since we talked about physician burnout and also new innovations in AI. What do you think are some of the tools that we can use, especially since that we still don't use electronic patient records, so most of the tools we cannot be used here. What type of tools do you think we can use to reduce the burden in an already chaotic setting?
So AI can be helpful in various ways to prevent and minimize burnout. There's various AI-based tools that we can use to track the mental health of the clinicians, because I think, especially in the Sri Lankan setup, the mental health of clinicians is probably a neglected area that's not being discussed very much. So I think we can use these AI-based tools to track the health and probably collect some data related to that as well, and help provide them with the necessary help. And also, there are certain sort of generative predictive text type tools that will give useful suggestions to the users on how to prevent their burnout. And then from a broader point of view, in the form of reducing workload, tools that would help triaging, would help the clinicians to reduce the administrative burden. For example, if you have a clinic in general medicine in a tertiary care hospital or even in a rural hospital, if you get 200 patients referred to your clinic, if you can use an AI triage tool to triage these patients to determine which ones need to be seen early and which ones could wait for an appointment in a few weeks' time, that would reduce the number of patients that you need to see immediately in your next clinic. So I think in busy setups like that, you could use various AI tools to minimize the burden.
To ask Dr. Dumitha, so you nicely pointed out the challenges that the young internists experience. We have some of the young internists and budding physicians here. So what is the role of professional colleges like CCP in empowering them and trying to retain them in Sri Lanka, especially with regards to shaping the policies and also improving their well-being?
Thank you, Rakitha. It's an excellent question. Yes, so the CCP is doing a lot of work for the young budding physicians and young internists. So as you all know, we are supporting their education by conducting various training programs, as well as we are conducting a lot of CME activities. On the other hand, we have various other platforms where these budding physicians can join CCP. Like we have book clubs, regional meetings, where they can be part of our academic program. Also, we help young internists to secure overseas training through our collaborations with RCP, and we run MRCP PACES here in Sri Lanka. And last year, we collaborated with EFIM. I think through EFIM, our young internists would get a lot of opportunities, as Professor Dalekos highlighted during his talk. There are a lot of exchange programs, summer and winter camps, and you can collaborate with your international colleagues to conduct research and all. So I think at the moment there are a lot of activities happening in the CCP for the young internists.
I would like to comment on the burnout. There is no doubt that the burnout is here, okay, everywhere, okay. But everybody is talking about how to minimize, to decrease burnout, etc. What Miguel made a fantastic presentation. But nobody is talking about the resources and the politicians. You know, in EU, Miguel showed that in EU, we have a directiva to take care about the residents for this. But when the national societies are asking more positions in our departments, because this is a number, a kind of solution for this, to have more residents in small groups in your department. Nobody wants to have new position. You know, everything is money. So nobody is talking about this. I don't know how it's here in Sri Lanka, but this is, at least in Europe, a universal problem in Europe and also in UK, I suppose.
I have two questions. First to the professor. I have one question to you. So this is behalf of our young doctors who are awaiting the foreign training. You know, the Sri Lankan system, we have mandatory local training and we have to do the overseas training in either UK or the Australia. So I'm asking, what is the possibility of doing this overseas training in the European Federation? The main problem I feel is the language. The main barrier is the language, because European Union, there's a few countries that speak in the English.
You mean for the exchange program?
No. As an overseas training, as a clinical fellowship.
This is separately according to its country. It's different in Greece, in Spain, or in Italy, etc. And this is governed by the Ministry of Health. And we have some scholarships, and you can do, of course, residency, not only in internal medicine, whatever, but there are some requirements for this. And the decision is made by the Ministry of Health, not by the university hospital.
Is Miguel with us?
Yes.
Hi, Miguel.
I'm listening.
Excellent presentation. You talked about the burnout, but when it comes to the number of trainees and people, as Prof said, in a unit, we see that, for example, if you take UK, the junior doctors, it's very hard to get into a junior post currently. Yet the doctors who work complain that they are overworked. Do you think that that I guess probably in Sri Lanka it's somewhat similar to burnout. But do you think that the influence could be done at a higher level where like a governing body should basically look into that more seriously? So that
hello everyone, and yeah, I hope you are listening. And first of all, I just wanted to thank again for the opportunity to be here and to be discussing and hear such huge and topics and wonderful presentations. So thank you for everything. And regarding the question, it's a wonderful question, and of course we should aim to do some kind of advocacy at the higher levels and try to show how important and how present nowadays burnout is over the medical community. Job is being done with the service, showing the numbers, and I think for some experience now that mental health issues are grabbing more and more attention. Of course, it will be always a work in progress and will not be easy. The balance between education and between the needed hours to educate and to rise in our profession will be always against the level of burnout that we will achieve. But again, there are directives, there are some policy making strategies now, but we can do some work within our levels, national, European levels, within EFIM and over Asia, I think. So I think we should aim for higher advocacy, but starting locally or nationally, try to implement some strategies and then show the results as UK did. And as you said, there is a huge amount of burnout there, but they are trying, and they are one of the countries presenting some work on those areas.
Thank you. Keshini, I have a question. So now you mentioned about the new concepts that we get familiarized during the overseas training. Of course, clinical medicine, we have enough clinical material here. We are quite conversant, but new concepts like quality improvement projects and the DATEX, the incident reporting, and so on. So what challenges do you expect to see when you try to adapt or apply these new concepts to the Sri Lankan setting, especially given the economic and resource constraints?
I think one of the main challenges that you might encounter is bureaucracy here in Sri Lanka. So if you try to implement something new, you will also have to go through a lot of hoops, a lot of bureaucratic hoops to get approvals and things, especially to collect data. And some people might not be very open to us evaluating the practice of a certain hospital if it involves other clinicians as well, because there will be a comparison in like mortality statistics, and some people might not be very open to their practice being evaluated. So I think those are some of the challenges that we might have to face in implementing quality improvement activities here.
Yes, thank you. And I think the absence of electronic health records is also a major issue in our setup.
I have one last question, either to Dr. Dumitha or the primary citizen is in the audience. This is actually more political or the administrative question. When the young internists or someone returned from the UK, Australia to Sri Lanka, they will be posted to Padaviya or somewhere without any policy. I know that. The ministry level, they don't have recorded or the system to post them. I believe personally, because I experienced that and I have backbone to face that. What I feel is, they are, in addition to this, considering the age or seniority matters, at least there should be a performance-based marking system, depending on how many transplant you did, where you practice. We can give 80% portion or 70% portion to the seniority, at least 20% or 30% interview-based, performance-based interview system to give the post to the young consultant. Definitely most of them will retain in the country. At least we see there is a transparency and they will come. But I don't think the ministry will implement this in next 10 years or 20 years. And though we talk so many things, I don't think people will return. I know how many people left the Rakitha no, Solith no, left the country because we know there is no transparency in putting the people in the after return from the overseas training. The TCS and the people, they do whatever they want. So what is the I know sir is the next president-elect, probably, and CCP would take action to prevent this. What do you think, madam?
Yeah, I think it's a good question, and actually it's a fault not only from the administration, it's fault of us as well, because we have been neglecting this aspect of advocacy and involving in policy decision making as a professional organization. So we have been compelled, or we have been very comfortable doing our academic activities and teaching and whatever the clinical activities, and remaining ourselves as a professional organization very confined to ourselves. So I think we need to come out of this self-comforting area, and we need to get involved with policy decision making and advocacy to administration. Since we are not being visible in that level, all these are happening, and we should show that the professionals, as professionals, we know what we need, and we know what country needs from the clinical point, or whatever the health needs, and we should have a voice from our professional colleges to direct policymakers. Otherwise, if we are not getting involved at that level, we'll be receiving all these unnecessary and very unwanted things happening without our wish and against our wish from the administration as well as many other levels. So that is in the future, the CCP is going to direct in that level. The advocacy and policy making level participation will be more. And you can't correct it over a month or a year, but we have to get ourselves organized to face this challenge. I think that is the only way that, because most of these organizations in clinic, worldwide, take RCP, they are heavily involved with advocacy and policy making. So why not us? And because we feel that it's not our job, but I think as professionals we have a great opportunity and also a big responsibility to get involved in these matters. So I think there is no short answer for that.
So in the interest of time, so we can allow 1 or 2 questions from the audience if there is any. Okay, so thank you very much for participating in the discussion. So now I'll invite my co-chair, Dr. Chanaka Abeyratne, to present the token of appreciation to the speakers. So George Dalekos, Professor George Dalekos. Okay. Okay, so Dr. Dumitha Govindapala. Dr. Keshani Samarasekar. the certificate of appreciation for the panelists.
Rakitha Higgoda. Vihangi Fernando. And Dr. Solith Senanayake. Okay. So, that will conclude our symposium and the session.